whenever, okay, as and when you will say live, Dr. Narsingh Verma will initiate.
Yes, sir, we are live.
Okay, thank you. So a very good evening to you all. I am Professor Narsingh Verma, and I am at present Secretary General of Indian Society of Hypertension. And this is very nice that we are going to start this program on the day of the World Hypertension Day. And this year, the theme of the World Hypertension Day is very liking to me, because since last 15 years, I'm trying to create the knowledge regarding the actual measurement of blood pressure, or I was trying hard to say that the blood pressure measurement is more important. And this time, the theme is that measure your blood pressure correctly and control it and live longer. That is fine. If you know, then only you can control it. And only after the correct measurement, we can control it. And definitely, when we can control it, we will live long. So with this message, I think it is high time that we are going to start today's program. And definitely we will welcome all your questions, because we have very good panel. Dr. Anil Virmani, the prolific speaker, and definitely we have with us Professor Anuj Maheshwari, who is the backbone of Indian Society of Hypertension. And I invite him for further proceedings. Professor Anuj Maheshwari.
Thank you, sir. It's a really pleasurable time that we are seeing you here on this platform after long duration of the illness, and you have been recovered well, and we are really thankful of the God that you are among us with full of your energy. With these words, today is the World Hypertension Day. As Dr. Verma has said already, that World Hypertension Day, we must take a pledge that we will keep our own blood pressure within normal limit, within 130/80, and we will keep all our relatives, all our friends, as well as all our patients under the target of 130/80, come what may. It's not necessary only we should use the drugs. There are multiple things before we start the drug. We should keep our lifestyle better. We should also take the good sleep. We should reduce the salt. We should avoid the fast food. We should do the enough exercise. And with doing that, if we are not being able to keep our blood pressure within the target, then we should think about the drugs, and we should go to our doctor to get enough consultation, to enough medication, whatever he wished to give us. With these words, I would like to start the program of the day. This is the fourth module of our hypertension activist course of Indian Society of Hypertension, what we are doing with the active support of Lupin. And these people are really doing the wonderful support to our society in these times. And this is the fourth and last module. And as per our old commitment, the candidate, those who have already completed 3 modules, and they will also be completing the 4th module, they will be given the certificate. They will be felicitated with the certificate of Hypertension Activist 2020 from Indian Society of Hypertension. With these words, we are progressing towards the 4th module, that is on resistant hypertension as well as management of the hypertension in the comorbidities. And this will be taken by our very learned and prolific speaker, Dr. Anil K. Virmani, who is a very well-known face in country, not only for the hypertension, but also in the diabetes. And we have listened him on multiple forums. He is a very good speaker, and he is a practitioner in he's practitioner in Tata Nagar, Jamshedpur, and he is a very well-known speaker of the Jharkhand. He is a well-known faculty of the Jharkhand. He has initiated the Jharkhand chapter of RSSDI, and detailed introduction of Dr. Anil Virmani. He has been awarded the Fellow of Indian College of Physicians. He has been awarded the Fellowship of the Indian College Association of the Clinical Medicine, as well as he is well-known Fellow of the American College of the Physician, Diabetes India, and he has also been awarded one fellowship of our Indian Society of Hypertension also. He is founder member of the Clinical Cardio-Diabetes Society of India, He is Chairman Indian Association of the Clinical Medicine Jharkhand chapter, Vice President Clinical Cardio Diabetes Society, Regional Faculty of the multiple organization PHFI, Diabetes India, ACMDC, CCTMD, CCGDM, CCEBDM, whatever course the PHFI runs, in every course he is working as a regional faculty. He is the speaker at national international conferences, which I have already told to you. With this introduction, I request Dr. Anil Virmani to come forward for his presentation and deliberation, which we are waiting for long. Over to Dr. Virmani.
Thank you, Professor Anuj Maheshwari. At the outset, I would like to thank both Professor Narsingh Verma and Professor Anuj Maheshwari for giving me this honor to give the last module on the World Hypertension Day. And I also like to thank the Lupin Pharma for their wonderful cooperation and their support. As told by Professor Narsingh Verma, today, the World Hypertension Day, the theme is measure your blood pressure, control it, live longer. Now, my topic for today is hypertension in different comorbid conditions and resistant hypertension. So what I plan to do is, I will talk about hypertension and diabetes. I'll talk about malignant hypertension. I will mention something about salt-sensitive hypertension. Then I'll go to resistant hypertension, where I'll discuss its prevalence, definition, etiology, complications, evaluation and management, and finally conclude. Now, we all know that hypertension affects approximately 20 to 60% of patients with diabetes, depending on obesity, ethnicity, and age. And it leads to a 2 to 3-fold increase in major cardiovascular events in both type 1 and type 2 diabetes. If you look at type 1 patients, almost at diagnosis, 20 to 40% of these patients have hypertension, 30 to 50% with microalbuminuria, and 65 to 88 with macroalbuminuria. On the other hand, if we look at type 2 diabetes, almost 50% of these patients have hypertension at diagnosis, 80% have microalbuminuria, and more than 90% have macroalbuminuria. In type 1 diabetes, hypertension reflects the onset of diabetic nephropathy, while in type 2, it is often present as a part of the metabolic syndrome. So there is increased risk of diabetes-specific complications, including retinopathy and nephropathy. Up to 75% of cardiovascular disease in diabetes is attributed to hypertension. Way back, the UKPDS showed us that in each 10 millimeter reduction in mean systolic blood pressure was associated with reductions in the risk for any complication related to diabetes by 12%, MI by 11%, and microvascular complications by 13%. Now, diabetes and hypertension are said to be partners in crime, just to show that a person who has hypertension compared to a person who does not have hypertension has more than 2.4 chances of becoming a diabetic. On the other hand, a person with diabetes as compared to a non-diabetic has twice the chance of becoming a hypertensive. Now, it is very important to realize that the common denominator of both hypertension and diabetes target organ disease or damage is the vascular tree. So it is a vascular tree that bears the brunt by both diabetes and hypertension. And if we look at the time trajectories, it has been seen that development of hypertension and diabetes, they track each other over time. As I said, they are after all partners in crime. And transition from normotension to hypertension is characterized by a sharp increase in blood pressure value. And the common denominator is insulin resistance, which is seen both in pre-diabetes and pre-hypertension. And that is an antecedent of progression to to both the respective disease states. Now, which blood pressure is systolic or diastolic, that is important. We see that in patients with diabetes as compared to non-diabetes, every 20/10 rise in the blood pressure or every 20 millimeter rise in the systolic blood pressure leads to a mortality risk almost doubling. So it is clear that systolic blood pressure is a stronger predictor of risk than diastolic blood pressure as far as cardiovascular disease is concerned and as far as diabetic nephropathy is concerned. In fact, 65% of the patients with diabetes and hypertension have isolated systolic hypertension. And we all know that isolated systolic hypertension is more difficult to control as compared to essential otherwise hypertension. The, both the joint European guidelines published in 2018 by the European Society of Cardiology and European Society of Hypertension use a risk factor. And if you see stage 2 and stage 2 where there is diabetes without organ damage is moderate to high risk and high risk. And depending on the blood pressure, it can be very high risk. Whereas diabetes with organ damage, irrespective of the blood pressure, is very high risk. Plus, they have a scoring system for cardiovascular event depending on the age, the gender, whether person is a smoker or non-smoker, the cholesterol levels, and the systolic blood pressure. And for the first time, any international guideline looked at the South Asians, and they said that the risk for Asians is more by 40%. So whatever risk factor that is derived there has to be increased by 40% to know what is the risk factor for the Southern Asians or for Asians like us. Now, when we look at these patients with diabetes, blood pressure should be measured at every routine clinical visit. And if the blood pressure is more than 140/90, it should be confirmed using multiple readings, including measurements on a separate day to put the diagnosis of hypertension as a stamp. In fact, the Canadian guidelines are more stringent and they ask for measurement on 4 to 5 separate occasions or self-monitoring or ambulatory blood pressure before the diagnosis is made. However, it is now mandatory that all hypertensive patients with diabetes should have home monitoring of blood pressure to identify white coat hypertension. Now, what is important? It is the sustained aspect of hypertension is more important as blood pressure has considerable normal variation, not to undermine what is known as blood pressure variability, which is another very important prognostic factor. So and we must also remember that there is something called threshold for diagnosis and a treatment goal, and both are different, as I'll tell you in the end. Now, it is also very important to measure for orthostatic hypotension, and this should be done during the initial evaluation of hypertension and periodically at follow-up or when symptoms of orthostatic hypotension are present, and regularly if once you have diagnosed orthostatic hypotension. Now, it is how do you define orthostatic hypotension? It is said to be a decrease in a systolic blood pressure of 20 or a diastolic blood pressure of 10 millimeters of mercury within 3 minutes of standing from the sitting or supine position. So this diagnosis is very clear. A fall in blood pressure of 20/10 within 3 minutes of standing when compared with blood pressure from sitting or supine position. And it has known to be associated with increased risk of mortality and heart failure. Now, it is recommended by the ADA that patients receiving pharmacological therapy, uh, antihypertensive treatment should be measured to promote patient engagement in treatment and adherence. So it is very important that home monitoring of blood pressure should be done for all patients. Now, this home monitoring of blood pressure not only improves patient medication adherence and reduces cardiovascular factors. Furthermore, evidence suggests that home blood pressure monitoring is as accurate as a 24-hour ambulatory blood pressure monitoring and may better correlate with atherosclerotic cardiovascular risk than office measurements. So it is a better prognostic factor compared to the office blood pressure measurement as far as the cardiovascular risk is concerned. Now, if you look at the systemic review, blood pressure lowering in type 2 diabetes, we see there is a consistent reduction in the various cardiovascular events and a 13% reduction in all-cause mortality. So we have to get the blood pressure down to less than 140 by 90 to see this reduction. And this was with 10 millimeter systolic BP reduction. Recently, in the European Society of Cardiology press release, look at the fantastic benefits with only 5 millimeter decrease in systolic blood pressure, a 14% decrease in the heart failure, 13% in stroke, 10% in major CV events, 7% in ischemic heart disease, and 5% in mortality. So when we compare tight glucose control with tight blood pressure control, this is the benefit seen with tight glucose control in stroke, in death, mortality, and in microvascular complications. But when we do tight blood pressure control, look at the benefits on stroke, any endpoint, and the complication, microvascular complications. So, what are the benefits of intensive blood pressure treatment in patients with type 2 diabetes receiving standard but not intensive glycemic control? And this was a trial done, and it was seen that they wanted to look at first cardiovascular event in patients receiving standard versus intensive glycemic control. And this was the data from the Accord BP trial, and the follow-up was almost for 4.5 years. So what did they find? They saw that the cardiovascular event risk in patients receiving standard glycemic control was significantly lower in the intensive blood pressure treatment group than in the standard BP treatment group. And patients receiving intensive glycemic control did not differ significantly between the groups. So the take-home message here is that the benefits of intensive BP treatment were observed only in those patients who received standard glycemic control without additional risk factors. It is quite possible that intensive glycemic control led to increase in the hypoglycemia and canceled out some of the benefits of intensive blood pressure control. Now, if you look at in a patient with diabetes treated for 5 years, you're going to lower the A1C by 0.9%. You will have a reduction in cardiovascular events by around 2.9. If you lower the LDL-C by 1 millimole per liter, the reduction in the cardiovascular events is 8.2. But if you lower the systolic blood pressure by 4 millimeters, there is a reduction of cardiovascular events by 12.5. So this just only signifies how important it is to reduce blood pressure even over reduction of the glycemic control or dyslipidemia. Now, these are two very interesting studies I'm going to talk about. This is a meta systemic review and meta analysis consisting of 49 trials, more than 73,000 patients, published in BMJ in 2016. And they said if the baseline systolic blood pressure is greater than 150 millimeters of mercury, giving any antihypertensive treatment reduce the risk of all-cause mortality by 11%, cardiovascular mortality by 25%, stroke by 23%, and end-stage renal disease by 18%. And if the baseline systolic blood pressure is between 140 to 150, we have additional benefits in the reductions of all-cause mortality, MI, and heart failure. But when the blood pressure was brought to less than 140, it was seen that there was an increased risk of cardiovascular mortality by around 15%, with a tendency towards an increased risk of all-cause mortality. Now, after this study, another study was published just immediately after, and this was done in patients with type 2 diabetes who had no previous cardiovascular disease. In the previous study, the patients were not differentiated. Here, they took out patients who had no cardiovascular disease, and this was almost around 1,87,000 patients. And what did they find? That if the systolic blood pressure was reduced to between 110 to 119, they had significantly lower risk for non-fatal AMI and total MI, non-fatal stroke, non-fatal CVD, total CVD, and non-fatal CHD by 15% compared to patients who had a systolic blood pressure of 130 to 139. So here they favored that you could go down to even less than 120. But unfortunately, what happened? When you went down to less than 120, the risks were significantly higher, almost 20% for heart failure, 28% for all-cause death, and this group had, as compared to those group who were between 130 to 139. So participants with systolic BP of more than 140 had a higher risk for most outcomes. So now we came to know that somewhere between 120 and 140 is the safe range. Now, it is also important to realize here that the baseline systolic blood pressure of less than 130 conferred significantly lower risk for adverse cardiovascular events than did systolic blood pressure of 130 to 139. And it also suggests that the association between low baseline systolic blood pressure and all-cause death is not due primarily to cardiovascular disease, but rather to concomitant disease or patient factors that led to both low blood pressure and excess risk. And that brings us to what is known as the J curve. The J curve means is the Jacob hypothesis that if the blood pressure is more than 140 by 90, there is increased risk of cardiovascular events. And if the blood pressure is less than 120 by 70, again there is increased cardiovascular death, MI, all-cause death, hospital admission for heart failure, except for stroke. Now, this is a very controversial subject. It was denied by some of the studies, and it was post hoc analysis of certain interventional trials supported. But the conclusion is very simple, that this is applicable to patients with hypertension and coronary artery disease only. So if a patient does not have coronary artery disease, it is safe to go down to a blood pressure of even a diastolic blood pressure of even 60. But in those with coronary artery disease, one should not lower the pressure below 120 by 70. Now, a word about isolated diastolic hypertension. We all talk about isolated systolic hypertension. Now, when the cutoff was brought down from 140 by 90 to 130 by 80 by the American College of Cardiology and American Heart Association in 2017, there was a problem because this was based on expert opinion, not on trial data. And this change had major implications for an entity known as isolated diastolic hypertension, and that is defined as a systolic BP of less than 130 millimeter and a diastolic BP greater to or equal to 80. So if you have a patient of say 120 by 100, he is isolated diastolic hypertension. or even 120/90 as per this definition. Now, what is this? What is the significance of this isolated diastolic hypertension? It is said to be more common in younger individuals and is associated with future systolic hypertension, but not associated with adverse cardiovascular outcomes independent of baseline systolic BP. And these patients are generally young and obese, and the only treatment is lifestyle modification and weight reduction. Coming to malignant hypertension, traditionally defined as a blood pressure of more than 220/120 with the presence of target organ damage and essentially including the presence of papilledema. So papilledema is supposed to be present for the diagnosis of malignant hypertension. That was the traditional definition. Today, the modern definition has said that it is an hypertensive emergency. That is, when there is an acutely elevated blood pressure with damage to minimum three different organs in the absence of retinopathy. So papilledema may not be there. Still, it will be called malignant hypertension if three organs have been involved, and it requires immediate steps to reduce BP in minutes to hours. Now, this hypertensive emergencies is in contrast to what is known as hypertensive urgency. Here also the BP is same, more than 220/120, but there is no target organ damage. So sudden reductions of blood pressure by aggressive therapy should not be done because they may be harmful and they may lead to hypoperfusion of the target organs. Now, any secondary cause of hypertension can lead to malignant hypertension, including pregnancy complications like preeclampsia and eclampsia. In fact, 1% of the patients with essential hypertension will develop malignant hypertension. There are three independent predictors of survival: the age, the baseline serum creatinine level, and follow-up systolic blood pressure levels. The classical vascular lesion is a fibrinoid necrosis of the arterioles, leading to microangiopathic hemolytic anemia, and there is dilatation of cerebral arteries, breakthrough of the normal cerebral autoregulation, hypoperfusion, and cerebral edema, leading to the classical features of hypertensive encephalopathy. The classical clinical manifestations are chest pain, breathlessness, and a neurological deficit. We have to take a detailed history, a thorough clinical examination of all the target organ sites, including fundoscopy. The initial targets of BP control and the speed in which it should be reduced depends on the assessment of associated comorbidities. Overzealous BP reduction may be harmful and lead to organ hypoperfusion. Hence, it is better to put in an intra-arterial line to monitor blood pressure. That is the ideal situation. And the common drugs that are used are IV nitroprusside, nicardipine, labetalol, esmolol, metoprolol, in pregnancy, labetalol and hydrazine, phentolamine for pheochromocytoma. These are some of the drugs that are used in malignant hypertension. A word about something called salt-sensitive hypertension. Now, what happens? There is increased excitation of the sympathetic system, and there is leads to increased renal sodium retention during high salt intake. And these are the hallmarks of salt sensitivity of blood pressure. How it is occurring, we still don't know, but it is said that there is systemic release of norepinephrine, and this influences renal sodium reabsorption through the activity by stimulating the activity of what is known as sodium chloride co-transporters, and thus promotes the development of salt sensitive hypertension. So norepinephrine basically is the culprit here. And recently, a study has very nicely shown that the drug of choice in these patients who have a high sympathetic activity is actually an alpha 1 adenoreceptor blocker. So this is the drug of choice, alpha 1 adenoreceptor antagonist. I think no talk can be complete unless you touch COVID. I didn't want to talk of COVID here for two basic reasons. Number one, here hypertension is the comorbidity, not COVID. And number two, COVID, I think, is basically a viral disease which has gone rogue. So we have given too much importance to it and we have overreacted. I think it is nothing more than a petty criminal who has become a minister in the government. However, whatever it is, let us see what is the relationship with hypertension. If you look at the prevalence of hypertension in COVID infections, it is around 20.7%. And this is the as just like the prevalence of hypertension in the normal population. So if you have a controlled blood pressure, there is no chance you don't have an extra risk of getting a COVID-19 infection. But if the blood pressure is uncontrolled, then the mortality rate is high. Here you will see it's almost 48% in patients with uncontrolled hypertension compared to the survivors who had controlled hypertension. Now we all know the we should be treating hypertension just the way we treat in any other condition. The, the problem rose when there was a confusion regarding the AC2 receptor through which the virus replicates. So it is important to realize that this virus goes through the AC2, blocking it is the entry point, and this favors basically an angiotensin 2 generation. And there is unopposed action of the angiotensin 2 contributing to acute lung injury. The problem was, should we be using the RAS blockers? So now the consensus is very clear. The European Society of Cardiology Council on Hypertension statement have said that patients with hypertension should receive treatment with AC inhibitors and ARBs despite COVID-19 infection. If the patient goes into shock, then they should continue or discontinue depending on case-to-case basis by monitoring the electrolytes and renal function. The Hypertension Canada has also said that these patients should have their home blood pressure monitoring regularly. That is very important, and I think this is the opportunity to teach them home blood pressure monitoring. And they have asked that both the not only the ACRBs but even the RNA therapy is strongly recommended that it should be continued. The International Society of Hypertension has endorsed what the European Society of Cardiology said. Now that covers half my talk. Coming to the next half on resistant hypertension. Now, resistant hypertension has been defined as the blood pressure that remains above the goal in spite of concurrent use of three antihypertensive agents of different classes, one of which should be a diuretic. And patients whose BP is controlled with four or more medications and exclude pseudo-resistant and reversible organic causes. So when we are using a diuretic, one must remember that you must give at least 3 weeks for any directive to have a full antihypertensive effect. So we should wait, once you have started a diuretic, wait for 3 weeks before saying that this patient is not responding. As far as the goals are concerned, we all know 140 by 90 is the threshold, 130 by 80 is the target. Now the prevalence is increased from 95, it was 1.75%. In 2015, it is 6.46%. And prevalence was 13% amongst those who were already on treatment when you are considering 140 by 90. And if you think it is 130 by 80, it is going to be 4% higher. The prevalence in India, if you see of resistant hypertension, varies depending on the place, whether it's rural or in Mumbai or in the slums. But pan India, it is almost around 19.5 to 20%. And it is said that in the general population, it is low. In specialized clinics, it's around 15%, whereas the clinical trials is 30%, because obviously there is a bias selection of patients. But what is important to realize here, that patients with resistant hypertension are almost 50% more likely to experience an adverse cardiovascular event compared with patients with blood pressure control by three or fewer antihypertensive agents. If you look at this population of resistant hypertension here, they can be equally divided into three: 33% pseudo-resistant hypertension, 33% true resistant hypertension, and 33% controlled on more than 4 medications. So what is pseudo-resistance? Inaccurate measurement technique. Overestimation can be done because cuff is too small, proper seating measures are not taken, and all this have been discussed in the previous modules. Poor patient adherence, like medication side effects, dosing schedules, poor patient-doctor communication, inadequate patient education, psychiatric problems, the affordability of medications, or the patient may have heavily calcified or arteriosclerotic arteries that are difficult to compress, or physical inertia, physician's inertia, where there is failure to change or increase dose regimens when the patient is not at goal. We must differentiate between white coat hypertension and white coat effect. Now, white coat hypertension is an office blood pressure which is more than 140 by 90 on at least 3 occasions, while the average daytime or 24-hour blood pressure is less than 135 by 85. 15% prevalence in the general population and more than 30% in those already diagnosed as hypertensive. Now, there is a greater prevalence of target organ damage and metabolic abnormalities than that of the normotensive subjects. So, it is no longer a benign condition. On the other hand, a white coat effect is a transient elevation of the office blood pressure induced by the alerting response to a doctor or a nurse. And it can occur both in normotensives and hypertensive population. And the prognostic significance is a bit conflicting evidence is there. Most of the studies say that it is a benign condition. So we need to do either an ambulatory blood pressure monitoring or a home blood pressure monitoring to diagnose these. Now, these are some of the strong associates of resistant hypertension: type 2 diabetes, chronic kidney disease, presence of left ventricular hypertrophy, increased BMI, and obstructive sleep apnea syndrome. The causes: sympathetic neuronal activation like chronic stress, pain, fear, hyperventilation, paroxysm of panic fear. There may be various associated conditions like obesity, elderly, endocrine disorders, drug abuse, sleep apnea, accessory dietary sodium, the various drugs from NSAIDs, steroids, erythropoietin, cyclosporin, oral contraceptive, antidepressant, decongestants, herbal supplements, and hypervolemia, excessive sodium intake, heart failure, progressive renal insufficiency, inadequate diuretic usage, drugs that cause fluid retention. But clinically speaking, the causes can be either patient related, he is taking high salt, poor adherence, lack of lifestyle adherence, and intake of drugs that raise blood pressure, like herbal supplements or NSAIDs. Or it may be physician related, like a subclinical volume overload. We are not correcting the volume overload, inadequate use of diuretics, progressive renal insufficiency, and unsuspected secondary causes. The complications are well known: congestive heart failure, stroke, cardiovascular disease, end stage renal disease, and all cause mortality. Now, the three important things are left ventricular hypertrophy, hypertensive retinopathy, and a renal dysfunction in the form of persistently elevated urinary albumin excretion rates, hematuria, or renal impairment. There are four markers of organ damage that predict cardiovascular mortality: presence of albuminuria, increased pulse wave velocity, presence of left ventricular hypertrophy, and the presence of carotid plaques or increased wall thickness. Now, obesity is very commonly associated with resistant hypertension, the causes being insulin resistance and hyperinsulinemia. There is impaired sodium excretion, there is increase in the sympathetic flow, increased aldosterone sensitivity, and obstructive sleep apnea. The only answer is weight reduction, and the pillars of weight reduction are a behavioral modification, calories restriction in diet, regular exercise, and whatever limited pharmacotherapy that we have. Now, it is very important to look at secondary causes of resistant hypertension. Obstructive sleep apnea, seen almost in 60 to 70% cases, very high incidence. Diagnostic test, polysomnography, treatment, continuous positive airway pressure. Now, the index, apnea hypopnea index, is the way we measure, is the combined average number of apneas and hypopneas that occur per hour of sleep. And the classification, according to the American Academy of Sleep Medicine, mild is 5 to 15 events per hour, moderate is 15 to 30 events per hour, and severe is more than 30 events per hour. And there is, because of increase in the sympathetic activity, increased aldosterone levels, and increase in the reactive oxygen species with concomitant reduction in nitric oxide bioavailability. Another common is primary aldosteronism. It's more common than we thought earlier, and the prevalence is almost 70 to 20%. Diagnostic test is measuring the ratio between serum aldosterone and plasma renin activity, and treatment is the mineraloreceptor antagonist or surgical resection of the tumor. Now, this is different from the Cone syndrome because Cone syndrome is an adrenal aldosteronoma. That's a benign adrenal neoplasm. And here it is negative imaging, idiopathic. Hypokalemia may be a late manifestation. Normokalemia is quite common. But the catch point here, the crux of the message is that a patient presenting with hypertension and hypokalemia think of primary aldosteronism. And you screen him for the electrolytes, sodium, potassium, magnesium, bicarbonate, and plasma aldosterone to plasma renin activity ratio. The renal artery stenosis is also relatively not uncommon, 2 to 25%. Duplet Doppler ultrasonography, CT, or renal angiography. The treatment is renal revascularization in selected patients. Now, 90% of the renal artery stenosis is atherosclerotic in origin. These are elderly patients, smokers. They have known atherosclerotic disease, especially peripheral arterial disease, and unexplained renal insufficiency. In bilateral renal artery stenosis should be suspected in patients with history of flash or episodic pulmonary edema, especially when echo indicates a preserved systolic heart function. Another very important is the presence of renal parenchymal disease, prevalence 1 to 2%. You have to do a serum creatinine, EGFR, ultrasound, and correct the underlying causes and choose the right diuretic. This is the commonest secondary medical cause of hypertension. And failure to appreciate this relationship may cause inappropriate choice of drug. In, in fact, the diuretic chosen should be the right diuretic in these patients. And I'll talk about it a bit later. Then drug-induced heavy alcohol abuse, that can be medical history will give you the answer, and they have to discontinue it. Then less than 1% may be the thyroidal dysfunction, and rare causes like pheochromocytoma, Cushing syndrome, coarctation of aorta, and intracranial tumors. There's another term called refractory hypertension. That is when the blood pressure is more than 140 by 90 with more than 5 different medications, including a diuretic and a mineraloreceptor antagonist. So here it's both diuretic plus MRA, and still the patient is getting refractory hypertension. Now, though the prevalence is less, around 5% compared to 10 to 20% in the resistant, these are normally younger patients, females, and there's nothing to do with aldosterone in short. They're likely to be more obese and they're likely to have diabetes. But the most important difference is that the patients with resistant hypertension are volume dependent, whereas the patients with refractory hypertension have increase in the sympathetic activity. And because they have increase in the sympathetic activity, the cardiovascular risk is higher. So refractory hypertension, obese, diabetics, increased sympathetic activity with higher CV risk, young females. The other routine investigations, I will not go into details. Everything has to be done right from ECG, fundoscopy, renal imaging, 24 hours urinary metanephritis, etc. Treatment, non-pharmaceutical treatment was discussed very well last time by Dr. Narsingan. I will not talk about it much, but yes, weight loss, a healthy diet, and reduction of intake of dietary sodium. Just one word here, I'll say that there it is mentioned that you give less than 1500 milligram of uh, uh, sodium intake. But that goal is difficult for many people to achieve, and that was derived from short-term studies in which diets were controlled but minimum outcome data was collected. So let us be very clear that reducing sodium intake is desirable for people with hypertension, and we have data supporting daily intake of around 2300 to 2400 milligram, and this data is very robust, and further reduction has minimal effects on the blood pressure. Physical activity, aerobic, dynamic resistance, isometric, moderation in alcohol intake. Okay. Now coming to the pharmacological treatment, treat the correctable cause, aggressive drug therapy. We must optimize current treatment, effective diuresis, that's very important, use of mineralocorticoid receptor antagonists, and we have other drugs. I'll just talk about them. This is a very common, you know which drugs to be used together and which not to be used. But the first line drugs, as I said, are diuretics. We have the thiazide diuretics. They are the initial therapy for elderly patients with isolated systolic hypertension. The various electrolyte disturbances, volume depletion, renal dysfunction, glucose intolerance can occur, hyperuricemia, gout. Then we have the loop diuretics. Their special indication is congestive heart failure, advanced chronic kidney disease, and we have the potassium sparing diuretics where there is no special indication. The second drugs is the calcium channel blockers. We have the pyridines, initial therapy for blacks and elderly patients with isolated systolic, and the edema is the pedal edema and gingival hyperplasia can occur. Then the non-hydrodiaphragms, mainly for arrhythmias. And then we have the RAS blockers. I will not go into further details, but it is important as far as resistant hypertension is concerned, you must review diuretic therapy because that is the mainstay of the treatment of resistant hypertension and should be optimized. Now, unfortunately, we know that inappropriate volume expansion contributes to treatment resistance. So, if we do not give proper diuretics, we will never be able to control the blood pressure. Most of the patients will require a long-acting thiazide diuretic. Furosemide has short half-life, so it has to be given more frequently. The problem is I've seen people writing tablet, furosemide, one tablet daily. That is not going to work. If you want to give it one daily, then use torsemide, which has a long half-life, and but monitor serum electrolytes. Now, among the diuretics, we have thiazide-like diuretics, two diuretics, chlorthalidone and indapamide. Now, it has been shown that compared to hydrochloroside, 50 milligram, chlorthalidone 25 has provided greater 24-hour ambulatory blood pressure reduction and usually during the nocturnal. So there is a superior BP reduction, prevents cardiovascular events, reduces mortality and morbidity, and has a long half-life. Similarly, indapamide, long-term BP control similar to hydrochlorothiazide, preserves renal function, prevents cardiovascular events when added to perindoprine, and no impact on glucose or lipid metabolism. In fact, these two are the thiazide-like diuretics that are most recommended, either clothalidone or indapamide, for patients with by all the guidelines, and you can use any one of them. Then we have the fourth line therapy, the mineralocorticoreceptor antagonist. I'll just come to that. And then fifth line, we have a lot of other drugs like beta blockers, alpha blockers. I'll just mention them in passing. But the fifth drug is very important. That is the mineralocorticoid receptor antagonist. Now, they have a very significant antihypertensive benefit when you add to an existing multi-drug regimen. You see the reduction in by addition of spironolactone in ASCOT trial, the additional reduction in systolic blood pressure by almost 22 millimeters and diastolic by 9.5. As it is, there is high prevalence of primary aldosteronism in resistant hypertension. And even in patients with normal aldosterone, spironolactone is good because it has antiproteinuric, improves heart failure symptoms. However, 10% may have gynecomastia. Only caution, do not use when serum creatinine more than 2.5 or potassium more than 5. And there is sufficient evidence, aspirin trial, pathway 2 trial, and they've all shown that 25 to 50 milligram of spironolactone is the most effective drug treatment for resistant hypertension, controlling resistant hypertension in 60% of patients, and 3%, 3 times as likely to be the best drug versus any other drug, and well tolerated with no significant adverse effects, provided the potassium and renal function is monitored. How does it act? It is not only an MR inhibitor, it reduces sodium reuptake, increases sodium and water excretion, but it also inhibits what is known as the pannexin 1 channels. The pannexin 1 channels are very important, and thus it acts as an alpha adrenoceptor antagonist. These pannexin 1 channels are expressed in multiple tissues, and they basically amplify vasoconstriction in response to alpha-adrenergic stimulation via purinergic signaling. So this spironolactone by blocking connection channels also has anti-inflammatory and anti-fibrotic effects. The best combination of a diuretic is a clothalidone 25 milligram plus spironolactone 12.5 to 15 milligram. That will control majority of the patients. We have two MRIs right now, spironolactone, problem of gynecomastia, eplerenone, gynecomastia less, but more costly. These are both steroidal, but the only problem is hyperkalemia risk. Then we have another drug in the offing, that is finrinone. It's a non-steroidal with minimal effects on potassium. It has undergone phase 3 studies. What about beta blockers? No longer first line. Atenolol increases central aortic pressure. If you want to use a beta blocker, use either carvedilol or labetalol. Other drugs are there, alpha blockers like prazosin, doxorubicin, but not to be used as monotherapy. They are basically an add-on. Again, minoxidil, potent vasodilator, hydrolysine, no evidence of CV benefit. So the optimal antihypertensive regimen is a RAS blocker with CCB, RAS blocker with thiazide diuretic, or the combination of the three. Avoid dual RAS blockers, avoid RAS blocker in beta, avoid beta and adrenergic drugs. What is new? Firibistat is an oral active brain aminopeptidase A inhibitor, which targets the brain-renin angiotensin system. And that is why it is controls the angiotensin 2 in the brain. And it has been seen that it reduces vasopressin release, increases diuresis, reduces extracellular volume, and decreases sympathetic tone, and thus leads to reduction in vascular resistance and improvement of baroreflex function. It is useful when RAS blockers are not effective, especially in obese, blacks, and low renin hypertension. Another new drug coming up is the dual endothelin receptor antagonist, aprocitentan, but it is still not available in the market. Now, device therapies, there are a number of device therapies. I'll just talk about some of them. Renal denervation is a minimally invasive catheter-based procedure, basically to disable the renal nerves within the sympathetic nervous system by 4 to 6 ablations, and it impacts the mechanical and hormonal activities of the kidney, as well as the electrical activation of the rest of the sympathetic nervous system. Initially, it showed good results in the reduction of systolic and diastolic blood pressure, but when compared to a sham, it failed. And why did it fail? Possibly because of patient selection, operative failure, technical failure, faulty catheter, we don't know. That was Simplicity 3. Simplicity 4 is ongoing. But one thing very important, that in the D-Nervata trial, spironolactone was shown to be superior to renal denervation therapy, not only lowering blood pressure, but also in organ damage regression, especially reduction in albuminuria. So what is new with renal denervation therapy? There are a number of trials that have recently reported, but the problem is we do not know, we are still to know what are the specific patient characteristics and comorbidities that are associated with future blood pressure change. And it remains of utmost importance to know which patient is going to get benefit. So at the moment, it is very premature. So we need long-term safety results. The other is a baroreflex activation, where you stimulate the carotid baroreceptors, basically to normalize sympathovagal imbalance by reducing the activity of the sympathetic nervous system while increasing parasympathetic nervous activity. These have not yet been approved by the FDA, and this is the RIOS system that was introduced initially. Then the other is creation of fixed size central AV anastomosis by using a vein, basically to increase arterial compliance. So to summarize, how do you manage resistant hypertension? Exclude other, this is from the American Heart Association 2018. Exclude other causes of hypertension, the secondary causes which I talked about, white coat effect, non-adherence to medication, sodium intake less than 2400 milligram per day, lifestyle interventions, more than 6 hours of uninterrupted sleep, dietary patterns, weight loss, exercise, optimized three-drug regimen, RAS blocker, CCB, diuretic at maximally tolerated diuretics, and diuretic type appropriate for kidney function. If the EGFR is low, less than 30, high-side diuretics will not work. Use a loop diuretic. Second step, if BP is not targeted, shift to chlorthalidone or indipamide. Step 3, add a mineraloreceptor antagonist. Step 4, if the heart rate is more than 70, you can add a beta blocker, either a metoprolol or a bisoprolol, or a combined beta blocker, alpha blocker, like labetalol or carbidopa. If beta blocker is contraindicated, you can add an alpha blocker. Still not at control, hydralazine. Still not at control, minoxidil. So this is the steps that have been recommended. Now, what are the future options? There are a number of drugs. Aliskiren is failed. We are waiting for new aldosterone antagonists and novel combination algorithms. Now, we all know that despite intensive antihypertensive treatment, some patients still do not achieve BP control. Almost in a study, it was shown that 10% of the patients remain refractory to maximal antihypertensive therapy. So we still, despite using more than 5 drugs. Now, I'll end with what I said is the threshold 140 by 90. You must remember, for all ages except for more than 80 years, where it is 160 by 90. Threshold is basically to diagnose hypertension, and this is the target less than 130 systolic, but not less than 120. And here it is not less than 70 plus. To wrap up, resistant hypertension is widely understood phenomenon. Patients with resistant hypertension are 50% more likely to experience an adverse cardiovascular event compared with patients with BP controlled by 3 or fewer antihypertensive agents. It requires a pathophysiology and clinical experience based treatment recommendations. The best available evidence supports the use of low-dose spironolactone as the preferred fourth drug if the patient's blood potassium level is less than 4.5, and with higher blood potassium levels, intensification of thiazide-like diuretic therapy should be considered. Use chlorthalidone or indapamide over hydrochlorothiazide. Device-based interventions need to prove their efficacy in further trials. Now, having talked so much, let me leave you with 3 pearls of wisdom. This is from my experience. Before setting any BP goals, first look at the patient sitting before you. Individualize the BP goal. The guidelines may say whatever they want to say. They are just to guide you. You have to look at the patient and individualize the BP goal. Once you have individualized the BP goal, shared decision making is vital. Have a partnership with your patient in achieving the BP total, BP goal targets. Unless you involve the patient will not be adhering to medications. This is the second most important. And number 3, be holistic. Let us treat the patient and not millimeters of doctor. With this, thank you for a patient hearing.
Presentation, I can say, masterly presentation by sir, and I think the MCQs will come, or we have to.
MCQs are there also.
MCQs will come. Dr. Anuj?
Dr. Monique, please start MCQs.
MCQs will come and then only we'll start. There are a lot of questions in chat box we will ask.
Sir, can you see the screen?
Yeah, yes, I can see the screen. The cardiovascular risk doubles with every increase in blood pressure by, the options are 10 by 5 mm of mercury, 20 by 10 mm of mercury, 30 by 15 mm of mercury, and last option is 25 and by 15 mm of mercury, means 25 systolic and 15 diastolic. So we are really looking for the answer.
All of them are have.
No, there will be some changes.
This is final.
Whenever the time is over, you please tell us the time is over. Dr. Virmani, you please would like to say something about these answers, because MCQs has been designed by you, so I think you must take it.
The answer is correct.
But we have got it wrong. As I thought, that 20 by 10 is, when the blood pressure rises by 20 by 10, the cardiovascular risk doubles. So the answer should be B.
The right answer is B.
Yeah.
93%.
Okay. The next MCQs, please show.
Only 7%.
The target goal of blood pressure in diabetes as per all guidelines is. Let us see what are the answers of the people. Monik, how can we know that time is over or not?
Sir, it's up to you. Timing, sir, it's up to you. You can give any time, sir. Then I will
Anytime.
pause. Well, you can give some time to the attendees, so all attendees can give the answer.
Because every second answer are changing, percentage of the answer is changing. So at least one cutoff you'll have to get after 10 second or 15 second, whatever is coming up.
In Buddha cutoff for 20 seconds.
Actually, 20 seconds is enough.
30 seconds is a better time.
20 seconds is enough.
Yeah, I think 20 seconds is enough.
Yeah. So Dr. Virmani, what is your comment?
I think majority have answered correctly.
Yes, right.
I-
Less than 130, 80 is the majority of the answer.
The
Right.
target
Yeah,
is 130 to 80, 140 by 90 is the threshold.
Still
Next,
some
please.
confusion.
No answer?
No answer. Huh? It will take time.
Sir, I request you to give at least 45 seconds to give answer, sir.
Okay.
Okay.
Yeah.
Okay. In the meantime, Dr. Anuj, you can read the question also. Yes.
इस बार मुकाबला तगड़ा है. चारों आंसर लोग टिक कर रहे हैं.
चेंज हो रहा है, बहुत तेजी से चेंज हो रहा है.
And see that all the 4 alternatives are being answered.
It looks like the stock market.
People are really confused between 10 and 20.
Dr. Virmani's talk was quite extensive, so probably some lack of concentration was there.
Well, I've forgotten what I said in the early
I
stage.
think 45 seconds is over. So Dr. Virmani, please give your comments.
As I said, their risk was 40%, 1.4. They put a risk factor of 1.4. So we have a very high risk of 40%. The right answer is D.
Right answer is
D.
D.
40%.
D, 40%. Okay.
Only 21%
So
have
only
responded.
21% people has given the answer.
We Asians have a very high risk as compared to the whites. So it is necessary
It is
to get our
21% higher than, oh, sorry, 40% higher than the
40% higher.
whites. Okay.
Yeah.
So next, please. I think 45 seconds are over. Dr. Virmani, your comments.
as I
Still
said,
changing.
these two partners in crime, hypertension and diabetes, their major brunt is on the vascular tree. That is
Yeah.
why
Right.
almost every organ in the body is involved,
Vascularity is
like
correct.
brain, eyes, heart, kidneys. So the answer is C, vascular tree.
Okay. So
39%.
many people are quite influenced by the kidneys because of the SGLT2 inhibitors.
Yeah.
So they may be thinking about the kidneys. So, but of course, you are right. The vascular tree is the common between the hypertension and
Yeah,
diabetes
it's
as
common.
denominator target organ damage. Next, please.
So you have to choose what is the blood pressure fall and in how many minutes. That
In
is
your talk, you have already mentioned it.
Yes, your comments, Dr. Vermani.
I think this is just a definition, so majority have got it correct. It is
Okay.
decrease
Next,
in
please.
blood pressure by 20/10 within 3 minutes.
Apnea, hyperapnea index.
Now, this is how to define severe obstructive sleep apnea depending on the number of events per hour as per the American Society guidelines.
Very, very fast changing.
Now it's over. Time is over.
Yeah, I think it is more than 30. The right answer is C. That is severe. Then less than 10 is the mild. Between 15 to 30 is moderate. And more than 30 is severe.
Okay. Next, please.
Only 18% were correct.
Yeah.
Again, this was very beautifully talked by Dr. Birmani.
I
think
think
this,
most of the questions were very well stressed by Dr. Virmani. I mean,
yeah,
he,
during
he
his
gave
talk,
ample time to those particular slides as well.
yeah. There was a slide on this. Still only 67% of them. He emphasized on this fact.
Yes, time is over.
I think majority are right. It is increase in
Okay.
sympathetic
Great.
activity.
Next, please.
Nobody is answering.
The drug of choice in salt-sensitive hypertension.
सभी दवा हो गई छोड़ के
25 all. Now, yes, time is over.
Okay, the right answer is alpha 1 blocker. Because as I said, this is one study that showed it blocks the sodium chloride co-transporter channels, and thus it decreases.
only 17% are
Yeah,
correct.
Most of the people thought about diuretics looking over the salt.
yeah.
They thought salt is there, and that's why diuretic must be
sensitive hypertension. Okay.
Next, please.
Next please. कोई अल्टरनेटिव छूटना नहीं चाहिए.
I think again the majority are correct. Is the connexin 1 channels I talked about. They are present almost in every tissue in the body.
Next, please.
So last question.
Yes.
I think this is also very easy question I put in. This is a common clinical cue that is given. Okay, I think majority are right. Any patient with hypertension with hypokalemia, think of primary aldosteronism.
Right. So these are the over of the MCQs. Now, Dr. Verma, we can take the questions. You please.
Yeah, one question from your side and then one by me.
Yes, you please start.
Now go to chat box. Chat box. How to go on?
Sir, from below side, there is one chat option.
Yeah.
So in the meantime, I should start.
Yeah.
So there is a question from Dr. Ajit Pal Singh, Dr. Vermani. A 35-year-old male known case of the epilepsy on phenytoin 300 milligram at bedtime and 100 milligram in the morning is having blood pressure around 160/90. Ideal antihypertensive in this case.
I think you can use a RAS blocker or a calcium channel blocker, any one of these two. Young fellow, there's no drug-to-drug interaction.
Okay. As far as the phenytoin is concerned, it is not very good drug for the patient, those who are having the hypertension. Especially, it has its bradycardia as well as lowering of the blood pressure also in itself. Despite taking the phenytoin, if a person is maintaining 160/90, I think losartan should be the best choice in this patient because it is known that phenytoin reduces the availability of calcium channel blockers. So if the phenytoin is being continued, either we should withdraw the phenytoin and go for the valproic acid. Otherwise, we should give losartan or any ARB kind of the drug that would be better in this situation. Another question is there. We find a case of the malignant hypertension on triple drug and go for adding an aldactone 25 milligram. How to follow up such patient potassium level and EGFR level, frequency of repeating tests and asking for follow-up.
If you're talking about a patient of malignant hypertension, as I said, this is a hypertensive emergency.
Yeah, this gentleman want to ask that how frequently we should repeat the test for the potassium level and EGFR level if a patient is taking aldactone.
Because this is a hypertensive emergency, the patient needs to be admitted and his blood pressure needs to be controlled immediately. He needs an intra-arterial pressure monitoring line. He needs the target organ damage has already been assessed, and based on that, he has to be very frequently monitored and his blood pressure controlled.
Yes.
Because it is already target organ damage has occurred. So this is an hypertensive emergency. You cannot treat him in the OPD.
Sir, Dr. Verma, will you take the other question?
चलिए मैं ऊपर पहुंच नहीं पा रहा हूँ.
आप नीचे वाले क्वेश्चन ले लीजिए ना, क्या दिक्कत है?
So there is one question from the about the renal sympathetic denervation. You have very well answered this, but he has asked that Dr. Abhay Narayan Rai, what is the latest status of renal sympathetic denervation in resistant hypertension?
The latest status is that we are still trying. I mean, it has shown some benefit in the couple of trials, but we are still trying to find out which patients are more suitable and what is the long-term effects. So right now it is reserved for very, very few patients who have failed on all drugs.
Okay. So you said that we are still waiting for the more outcome of the more trials which are going.
More profile of the patient, which patient is going to benefit and what is the long-term effect.
Dr. Amit Daira has asked one very important question. The maximum dose of torsemide, hydrochlorothiazide and chlorthalidone.
Chlorthalidone, you can go up to 50 milligram, but it is ideally better not to use more than 25 milligram. You can start with 6.25, but if you go more than 25, you must monitor the electrolytes and renal function. And torsemide is a loop diuretic. It's a long acting. You can go up to 40 milligram is the ideal. 20 to 40 is the ideal. We normally start with 10, 20, go up to maximum 40.
And one question from my side, which is almost near to the question asked by the Dr. Amit, that how you compare the hydrochlorothiazide, chlorthalidone, and indapamide.
Okay, now chlorthalidone and indapamide are the only two thiazide-like diuretics that have proven CV benefit as compared to hydrochlorothiazide. In fact, I've stopped using hydrochlorothiazide. As far as the electrolyte disturbance is concerned, it is similar both in hydrochlorothiazide and chlorthalidone. But because chlorthalidone is a much potent drug and it has got CV outcome benefits, I prefer to use chlorthalidone mostly. Indapamide is better than hydrochlorothiazide, but not as potent as chlorthalidone. Indapamide is a very good drug in elderly patients where you need a mild effect and you can, the blood pressure you have to reduce and it has got very little electrolyte disturbances.
Dr. Amit has asked that the hyponatremia, which is very common with the indapamide, how to prevent it?
See, this has to be monitored. Patients, but indapamide is very difficult. I mean, it's not very common to see electrolyte disturbances. It's a very, that way it is a very benign drug as far as the electrolyte disturbances are concerned. That's why I said it is one of the best drugs to be used in elderly people. And normally when it is used with, along in combination with perindopril, I think it's a very good combination. And then you don't see almost hardly any cases of electrolyte disturbances.
Basically, we have not encountered hyponatremia, which is he is mentioning. Have you seen the cases of
No,
hyponatremia?
no, no, no.
I have seen in one patient when in the early days of my practice, given indapamide, and he did not come for 3 4 days. And when I inquired about him, then he found that he has been admitted and the electrolyte imbalance, hyponatremia has occurred. And I was really very surprised for that. The only one case I have seen in my life
But it's
with the
a very
indapamide.
benign drug that way. It's a
Yeah.
very benign drug that way.
Yeah, definitely it is very benign, but and I was also very much shocked and that time, and that patient has also gone to some of my teacher also, and he asked that this young doctor has given me this drug, whether it was right or wrong. My teacher has also told me I never seen this kind of the complication with this drug. So this is quite rare, but when it occurs, it's very dangerous, very high, heavy hyponatremia takes place.
Dr. Anuj, please take more
Yes.
questions.
Next question, again, it is very interesting that what is the antihypertensive of the choice in elderly people?
Elderly people, isolated systolic hypertension, as I said, low dose thiazide diuretics or calcium channel blockers. And as I just mentioned, indapamide is a very good drug in elderly people.
Okay. Uh, he's asking very, again, a very pharma interesting question, pharma friendly question, I think, say. Azilsartan versus telmisartan versus olmesartan. Which is the most potent and which should be the preferred? Sir?
If you look only at the amount of blood pressure reduction, the most potent is azilsartan. There is no doubt about it. Number two, telmisartan, which has also got a 24 hours blood pressure control. And number three, olmesartan. Now, if you're looking at just reducing blood pressure, then azilsartan is the drug to use. But in patients with diabetes, in patients with metabolic syndrome, telmisartan is the drug to use. In patients with nephropathy, olmesartan is the drug to use.
What do you suggest the target blood pressure in stroke patients?
Recent stroke patients, if they are stable, try to get the blood pressure to less than 130/80, because intensive reductions of blood pressure, the maximum benefit is seen in stroke reduction.
Dr. Verma.
Yes. Dr. Amit has again asked one question. The dose of spironolactone and ipilimumab that can be used.
Spironolactone 12.5 milligram in combination with chlorthalidone is a wonderful combination, but you can go up to even 50 milligrams, even 100 milligrams, depending in patients with PCOS and patients with hirsutism. I've even used 100 milligram. But normally in the treatment of blood pressure, when I'm using as a combination drug, I normally use somewhere around 25 to 50 milligram.
And what is the incidence of hyperkalemia and gynecomastia?
See, you have to be very pharmacovigilant because hypokalemia can occur, and that is there with spironolactone, less with eplerenone, and the new drug that is going to come, finerenone, is not supposed to have any hyperkalemia. So you have to be very pharmacovigilant.
You told about a new drug, Febristate, whether it is available in India?
Not yet,
Not yet.
but
Dr. Anuj.
it has been approved by the FDA and it is available in the USA.
Resistant hypertension. Is there any order of using antihypertensive drugs?
Again, it will depend on the patient to patient. What is his age, gender, what are the present comorbidities? Depending on that, you have to choose a drug. If there is any compelling indication, like a patient, young patient with history of MI, a beta blocker would definitely be needed. A patient with diabetes, with albuminuria, definitely a RAS blocker. An elderly patient with calcium channel blocker, or a low dose thiazide diuretic. So it will depend on patient to patient. As I said, the whole treatment is individualized, and you have to first look at the patient, see the presence of comorbidities, set a target goal, involve the patient, and then treat him.
Diabetes and beta blocker. How much blood sugar derangement occurs, and which beta blocker is more efficient, carvedilol versus bisoprolol or metoprolol in a diabetic patient?
Okay. Now, the beta blockers initially were thought that by giving beta blockers, we will not be able to recognize the symptoms of hypoglycemia, because the symptoms of hypoglycemia are basically increase in the sympathetic nervous system activity, and beta blockers are going to block that. But then it was realized when beta blockers were being used for patients with coronary artery disease, then it was said that patients with diabetes with coronary artery disease should not be denied the benefit of a beta blocker. So beta blocker as such does not cause any glycemic disturbance as such, but then only thing is that hypoglycemia may be masked at times. Now, which is more efficient? If you look at that, the most commonly used drug is metoprolol today as a beta blocker for hypertension, though carvedilol is supposed to be one of the best drugs, but often underused. Bisoprolol, again used mainly by cardiologists, not by everyone, but the general physicians normally use metoprolol as the first drug, first beta blocker.
There is one question from Sneha Sakshi. She wants to know, because you have talked about the COVID also, if a person is suffering from diabetes, hypertension, and heart attack history is also there, can he be given ivermectin 12 milligram?
See, first of all, ivermectin has no role to play in the management of COVID. Let me be very, very clear, as I said, that we have been overreacting, we have been over medicating our patients. Just yesterday, the Solidarity trial came, and remdesivir, I don't know whether Dr. Narsingh Verma received remdesivir, but it has been shown that it is of no benefit at all. So at the moment, I think if you really want to treat a patient with COVID, I'm just going off the target now because this has become a huge controversy. I think the only treatment is a balanced diet, regular exercises to prevent it, and when you're falling, you're getting hypoxemic or fever is there, then the only treatments are oxygen therapy, low molecular weight heparin, and I don't think there is anything else that has given or proven efficacy in the treatment of COVID. So ivermectin as an anti-helminthic, okay, treatment of strongylitis, okay, I don't think there is any harm in giving one tablet. But for prophylaxis or for treatment, as has been mentioned initially by the UP government only, I do not agree to it and I do not believe it.
I think we can hear from Dr. Narsingh Verma himself.
Here, we should not think that this is only approved by the UP government. That's why you are not going to approve it. But I would like to share a few of the studies which has been done in the Asian population, and especially first information I received through the American College of Physicians Bangladesh chapter, that they are getting good results in their country while using ivermectin. At that time, we have not used ivermectin even in a single patient. We were using lot of hydroxychloroquine in our patient, and they have given this information by using the doxy and ivermectin combination. They have saved many patients from going into the ICU, and they saved their life there. So I think we should not go into this thing that if it is recommended by the UP government, that's why we are not following it.
It's not.
There are many other also who are promoting it, but definitely.
But if you really see the studies, the dose used is 100 times the actual dose. But it has been told that if you are using in human beings, then you need to give at least 4 to 5 times the dose, and it is not possible to give 4 to 5 times the dose. So what 12 milligrams we are giving is more of a placebo than, because it is definitely, I've talked with all the infectious disease specialists in the country and also got messages from across the country, across the world. And let me tell you, nobody believes that ivermectin is effective in this dose that is being recommended.
Everything is right, but only one thing is not correct, that nobody believes. So there are many people in world, those who are believing that it is working.
I'm talking about infectious disease specialists.
So it's
Right.
like we should not think nobody believes. There are some people who believes, and
Agreed.
I am also one of them. I don't think. I think Dr. Vijay Patni may be off. I
No,
don't
no,
think
no.
Dr.
Basically,
Narsimha Verma
we
will
have
be of that.
lot of Asian countries and Asian studies which they believe in. But definitely, yeah, even hydroxychloroquine was used very much in Bangladesh patient as well initially, and we Indians applied the molecule to them. So very difficult to deduce which one actually worked. That's
Correct.
what I can say.
So there are very strong supporters of HCQS and remdesivir even right now, despite data showing that they have no effects. So we don't know actually what is happening.
Data is not there for any drug.
Sir, it is a
So
hypertensive conclave.
everyone
Sir,
is
it is a
putting up his
hypertensive
hand in that
conclave.
dark. So we do not have
Hypertensive
enough data
module.
for any drug.
Desperate.
Sir, I think the current situation is that there is no treatment available for this particular disease.
Absolutely.
So whatever available, they are trying. I agree to Dr. Virmani. The latest data do not favor for even remdesivir and other drugs. And the last data have shown that there is hardly any effect of even antiviral remdesivir, which I also received for 5 days. But one thing is very clear: the steroids do have a role.
Yes.
Just after giving steroids, on third, fourth day, the patient becomes good. So that is one thing which has a role and proven role, and that we know from all viral pneumonias, these steroids have a role. But the question asked here was whether in the comorbid conditions of MI, hypertension, diabetes, it is safe to give ivermectin or not.
I don't know whether they should say any contraindication as such. If you're using 10
Yeah.
milligram, I don't find any contraindication. I think
Agreed,
it's
sir.
quite safe.
Agreed, sir. Sir, one very good question has been asked that Satish Kumar Prasad from Jharkhand, that diuretics of choice in pregnancy with Conn syndrome.
Diuretics should be avoided in pregnancy, number one.
With Conn syndrome, he's asking pregnancy with Conn syndrome.
The Conn syndrome is basically an adrenal adenoma.
Yeah.
The treatment is surgical. You can give aldosterone blocking agents like MRS, but in pregnancy, I don't think spironolactone is indicated. It is a category C drug for pregnancy. So either you wait, but otherwise the only drugs that are being, the first drug of choice for treating hypertension is labetalol. And then a calcium channel blocker, especially the cardia retard, the long-acting nifedipine. Even amlodipine there's no data with amlodipine. The third is alpha-methyl dopa, but that is now hardly available. So the only two drugs are labetalol and long-acting nifedipine. Steroids are not used. The surgical portion, it is for the surgeon and the gynecologist to decide if they want to go for an urgent surgery for Conn syndrome or they want to wait. But I definitely, I don't think there is any hurry. If you can control the blood pressure with labetalol and long-acting nifedipine. I don't know if there's any other opinion from the panelists, Dr. Vijay Patni or Dr. Anuj, I'll be happy to hear.
As far as pregnancy is concerned, there is a lot of controversies there. Even ADA was telling that about 2 years before, ADA was telling that you are free to keep blood pressure during the pregnancy till the 150 and systolic and 110 diastolic. But now this year, the recommendation has been changed. Every recommending authority is saying during the pregnancy, we have to keep less than 135 and 85 mm of mercury of the blood pressure. As far as the drugs are using, calcium channel blockers can be used safely. Of course, the labetalol beta blockers can be used, certain beta blockers, not every beta blockers can be used, but calcium channel blockers are being used safely in the absence of the alpha-methyl dopa. And in fact, alpha-methyl dopa is also not having very highly efficacy. So most of the time it is not so efficacious. We have to add one or another drug to this. But one thing is clear that ARBs and ACE inhibitors are definitely contraindicated. They should not be used. And diuretics should be avoided if it's possible. So this is my take on this.
Absolutely.
Dr. Vijay, if you want to add anything, you can add.
I can't disagree with you. It's absolutely what you said is absolutely correct, because diuretics should be avoided, and whatever we have, the CCB is probably the drug of choice which we are using it. And labetalol even is a problem. Let me tell you, to get the molecule in most of the centers. So, and this is a better beta blocker than any of the beta blockers which you can use in pregnancy. So I think I agree with you absolutely.
I don't know, Jamshedpur is freely available, so I use it as my first drug of choice. And if it is not there, then I add Nicardia, retard, or
yes, CCB is definitely is one of the better drugs. Yeah.
but no diuretics, no RAS blockers, definitely no.
Dr. Verma, I think questions are over. I think so.
I have two questions from Dr. Virmani.
Hello, can you listen?
Yeah,
me?
I have two questions to Dr. Virmani.
Yes, sir.
Dr. Virmani, one question is regarding the thyroid disorder and hypertension.
Your voice is little.
Thyroid dysfunction in hypertension.
Yeah, this comorbid condition.
Yes, good.
Yeah.
No.
See, thyroid, as far as hypothyroidism is concerned, we often see patients with isolated systolic hypertension. And once you correct the hypothyroidism, these patients normalize. Whereas patients with thyrotoxicosis who are in a hyperdynamic state often tend to have severe tachycardia and isolated systolic hypertension. But whether hypertension has any effect on the thyroid function, I am not aware of.
So, whether any special drug you will like to advise when hypothyroidism is there with hypertension?
Avoid beta blockers. Otherwise,
Avoid.
You can give any drug.
Another question, which is very old question asked by physicians, in your presentation, it was highlighted. That is why I'm asking this. The patient is having dyslipidemia, hyperglycemia, and hypertension. Out of these three, which one? Everything will be controlled in the coming time. Which one you would like to control very quickly? Hypertension, dyslipidemia, or hyperglycemia?
As I said, hypertension must be controlled immediately because chances of stroke are very high.
So that you have mentioned in your presentation. And last thing which I wanted to ask you about legacy effect, like in diabetes, whether in hypertension, we do have any legacy effect?
Sorry, which one?
Legacy effect. Like in diabetes, we have a legacy effect.
Okay, legacy effect. Yes, legacy effect. I think one of the trials did show that if you intensively treat blood pressure initially, there is a legacy effect. I'm forgetting which. I think it was a SHEP trial with chlorthalidone, if I am not mistaken, that showed a legacy effect. The initial intensive hypertensive treatment with chlorthalidone, after I think 15 years, it showed that these patients had much less cardiovascular outcomes compared to those who had not received chlorthalidone. That is one of the studies.
So that's all from my side. Any other questions, Dr. Anuj?
Dr. Anuj, do you remember any other study with the legacy effect?
About this hypertension?
Legacy effect in hypertension?
Yes. Advanced study has been done, which has shown the legacy effect. Advance on has shown the legacy effect. Of course, there has been some data came from the UPPDS also. Before we end, there is very important announcement. Of course, this 4-module course has been over now, and despite all odds, we could be able to reach at the end of this course. But lastly, we are going to announce a special digital knowledge network, which we are planning to have on the platform of Indian Society of Hypertension. This digital knowledge network will not only for the doctors, because we are doing a lot of CMEs for the doctors, but now we want that some of the case discussion, case clinic for the postgraduate, some postgraduate quizzes from programs for the nurses education, programs for the pharmacist education on the hypertension, because hypertension cannot be controlled until unless we do not make a team effort and we do not take all these things together. Although we have taken few names for this platform as an editor, but definitely we shall be going to add few more names here who will be showing their interest to work for this digital platform. So over to Monique would like to show that video which I have requested you to see. And on 25th of this month, and means next Sunday, we shall be going to formal inauguration of this digital knowledge platform at the same time, 8 p.m. So please show that video.
Indian Society of Hypertension presents to you Hypertension Knowledge Network, an innovative platform to share and view cutting-edge content for the clinicians to enhance their knowledge and implement in practice for better patient outcome. The objective is to bring cutting-edge content from leading experts by leveraging technology to scale the knowledge and skills of clinicians and better understanding by patients. Indian Society of Hypertension and Knowledge Bridge collaborate together for building a powerful learning and clinical decision support tools combined in one platform. Dr. Narsingan is a leading physician, internal medicine and cardiology. Dr. Narsingan has authored various articles and books and is a very active contributor to the science of hypertension and lipids. Dr. Narsingan, the current president of Indian Society of Hypertension, is taking this initiative with Dr. Anuj Maheshwari in launching the Hypertension Network, thus taking the lead in digital initiative from the society. Dr. Venkataram, a leading cardiologist and a senior hypertension specialist. He is a world authority on hypertension with lifelong work, research, clinical and publications. He is a global leader and speaker on hypertension, is well renowned for his contribution in the field. He has been the editor-in-chief of the Hypertension Journal for more than 7 years now. Dr. Mrinal Kanti Das needs no introduction. He has been at the helm of managing the activities of CSI for several years as the secretary and now as its president. Dr. Narsingh Verma is the Secretary General of the Indian Society of Hypertension. He is associated with the prestigious King George Medical University, Lucknow, India. Dr. A.K. Das is a senior faculty at JIPMER and has contributed numerous research articles and books as his contribution to science. Dr. Muthusamy is a highly experienced clinical and interventional cardiologist, with more than 40 years of medical practice and teaching experience behind him. Dr. Manisha Saha is the professor and head department of nephrology, Osmania General Hospital, India. She has been an active speaker at various national and international meetings. Dr. S. Ramakrishna Nat Ames is a senior faculty who has contributed to science with his writings in various national and international journals and several books. Dr. Anuj Maheshwari, the chief editor of the Hypertension Knowledge Network under the aegis of Indian Hypertension Society, is a young and dynamic physician who is technology savvy and finds the next generation of physicians will be native to technology. Thus his aim is to create a hypertension network at a time when digital transition is beginning to move towards the right direction in the healthcare sector in India. The HKN will provide the members with cutting-edge content in various forms which are elaborated here. Weekly key leaders corner visual learning experience to gain knowledge and communicate with the experts to clear doubts and dilemmas. Monthly case-based learning, challenging and interesting unique case presentations. Opportunity to discuss and ask questions and sort dilemmas regarding real-life cases. expert commentaries and reviews, identifying new research from leading journals and providing expert reviews on their strengths and shortcomings, an opportunity to decode complex trials and interpret to use in everyday practice. A platform with aggregated and curated content that can be shared and viewed by the ISH members, an asset for mentor development as well as skill enhancement of the ISH members and like-minded societies. A unique platform to achieve content and technology leadership with superior visibility and networking potential. Enhanced learning curve for the readers with multiple touch points to share and sort clinical dilemmas. Resources for the patients from ISH. Best technology put into work with best minds for content, a unison of tech and knowledge. A robust infrastructure architecture to support. Continuous marketing engagement throughout the year includes features such as printing of select content for one-to-one touch points, customized content for each communications, event-based communications. Reminder: leveraging WhatsApp for communications and engagement. App like web experience through notifications. Monthly one recorded call from top key opinion leaders. Equipped to add new ideas and ready to go to the next level of sharing and learning. Thank you, ISH and Knowledge Bridge, your technology partner.
So that's all. The description of this platform, what we are going to produce, and what the confirmation we have received from various KOLs, we have included their name, but there is further scope of getting more and more people in to get their services as well as to work for the people and the students on this platform. So we shall be looking for everyone's support here. Whosoever is listening will be benefited by doing that, and this is the one of the biggest benefit of becoming the member of the Indian Society of Hypertension. If you will become the member of the Indian Society of Hypertension, all these benefits are reaching to your door every month and whenever these are being planned for you. With these words, I will request Dr. Narsingh Verma to formally close this 4-module course of hypertension. Those who have been attended the all 4 modules, they will be given the certificates after getting the list from the organizers, Lupin people, who will be telling us who has attended all 4 modules, and we shall be sending the certificates to them. Over to Dr. Narsingh Verma for the final comments.
Thank you, Professor Maheshwari. I think I was not able to initial 3 modules to witness initial 3 modules, but today I can sense that these modules are extraordinary because the speaker has been given good time to talk about the things and a very good interaction. The questions are being asked by the attendees and moderators are also chipping in between. So it is a very good idea, and I will like to thank Dr. Maheshwari for advocating to this a particular idea, and definitely the physicians will learn a lot in the managing hypertension, and the motto of World Hypertension League and International Society of Hypertension, that the measure blood pressure correctly, control it, and live long can be achieved by our efforts. Thank you very much.
Thank you. Thank you, Dr. Vermani. Thank you, Dr. Vijay Patni, for being with us here.
Thank you.
Thank you.
Thank you, Lupin people, for all the cooperation you have did. Thank you, Monique. And thank you, Barnavana Basu, if she is there. I don't